Hi everyone. Good evening. Just was doing something with my stand so that I can adjust my phone. Along with that, I can do some charging, but it's not working. Any, Anyways, let us start with the class. Hi everyone. Good evening. Just a minute. Okay. Oh, this just a minute. My video capture device is not connected. Okay. So let us continue this marathon series from where we have left. So after discussing the topic of burn, today we shall be discussing more important topics. So one of the topic that I have selected for you is the concept of fluid and nutrition. Fluid and nutrition is equally important and it's very important. So when we talk about the concept of fluids, what are the must know things that we have to understand? The first is what is the volume requirement calculation. So this is again very important. Volume requirement calculation. This is point number one. The second is the flow rate estimation. The flow rate estimation. So volume requirement calculation and flow rate estimation. Flow rate calculation and then the choice of the fluid. So these are the three things that we need to understand and we will understand them smartly. Yeah. Okay. So when we talk about the volume requirement calculation, what are the important things that we need to understand? We have two formulas. Yeah. The volume in ml per day and the concept of volume in ml per hour. So ml per day and ml per hour. How do we see this ml per day and how do we see this ml per hour? Let us see. For first 10 kgs, it's different. Then for second 10 kgs, it's again different. And then it is for further kgs. So first 10 kgs, second 10 kgs and further kgs. Now when you talk about first 10 kgs in ml per day, it is 100 ml per kg for first 10 kgs, 50 ml per kg for second 10 kgs and 20 ml per kg for further kg. So it's like 150 20, 150 20. When we talk about the ml per hour, what is that and how do we see that? Ml per hour, it is 4 ml per kg for first 10 kgs. Then it is 2 ml per kg for next 10 kgs. And then it is 1 ml per kg for further kg. So 150 20 4 to 1. So let us take an example. If I want to calculate it for 80 kg patient, yeah. So how we do it? So for first 10, 100. Then for next 10, it is 50. And for further kgs, so that means remaining kgs out of 20, out of 60, 80 you have used 20. So you are left with 60 kgs. So 20 into 60. So if you total it, it comes out to be 1500 this way, and along with that 1200 this is. So 2700 ml per day. This is the per day requirement. Now when we talk about the same thing in ml per hour, so how do we calculate it? It's very simple, 4 to 1. So in ml per hour, it has to be for first 10 kgs, it is 4 ml. For next 10 kgs, it is 2 ml. And for remaining kgs, it is 1 ml. So 40, 20, 60, and that is 120 ml per hour. Students, if you multiply this 120 by 24 hours, you will get a value which is more than 2700. Now, why this disparity? Try to understand in surgery, nothing will go if you give 100 or 200 ml fluid extra. But if you forget the formula, this is the biggest disaster that can happen to this ecosystem. So remember, ideally this should have been 3.78 something like. But in order to make the formula easy, calculatable, memorizable and recallable, we just round it off to 4. So 4 to 1, 150, 20. This is how you calculate the fluid. The next challenge is to calculate the flow rate, and this is again very, very, very important. So flow rate estimation. So flow rate estimation. Now, how do you do this flow rate estimation? This is again very, very, very important. So when you talk about flow rate estimation, it is determined in terms of DPM. What do you mean by DPM, students? DPM stands for drops per minute. Drops per minute. Now, when you talk about drops per minute, there are two tricks that you need to follow. What are the two tricks? So drops per minute is defined as volume in ml per day divided by 100, or you can say volume in ml per hour divided by 4. So there are two tricks: volume in ml per day divided by 100, or volume in ml per hour divided by 4. So if you see this, this is simply like something like 2700 ml per day if you are talking about. So how many hundreds are there? 27. Now if you divide it by 100, it will be 27. So it is equal to 27 drops per minute. If you talk about 3200 ml per day, yeah, it will give to you 32 drops per minute. This is 32 drops per minute. This is what is very, very, very simple. This is making it easy and interesting. So 27, 32, this is all. Suppose someone says start with 100 ml per hour. So 100 ml per hour, how many drops per minute? Divided by 4, and that is 25 drops per minute. Are you getting this? This is what is making it easy. So volume in ml per hour divided by 4, or volume in ml per day divided by 100. This is what is very, 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 very easy. Very easy. Next is, let us try to understand few more important things that we need to be understanding it. Now, what about the choice of the fluid? So when you talk about the types of fluid, what are the types of fluids that we know and we can understand? There are three classical types of fluids that we have. We have crystalloid, we have crystalloids, we have colloids. So crystalloids, we have colloids, and we have blood and blood product. So blood and blood products. So crystalloid, colloid, and blood products. So when we talk about crystalloids, one very important thing is we have hypotonic, we have isotonic. So when you talk about hypotonic, what are the hypotonic fluids? Come on, students, someone from audience can answer this. 5% dextrose. So 5% dextrose comes under this category. Then what about isotonic? Isotonic fluid. When you talk about isotonic fluid, we have normal saline, so 0.9% normal saline. What else do we have, students? We have Ringer lactate. So Ringer lactate. The third is we have plasma light. Plasma light. So you can have isolate P, isolate M, isolate G. Isolate P is a special formulation for pediatric age group. Isolate M is maintenance. Isolate G is for the gastric secretions. So this is what is isotonic fluid all about, and amongst the fluids, basically it is the crystalloids which are the first line fluid of choice, and they're also the most commonly used, and amongst them either RL or NS. This is what is the cardinal fluid that we use. Then we have the hypertonic fluids. And when we talk about the hypertonic fluids, what are the important things that we need to understand here? We have 3 normal NaCl, point number 1. So 3 normal NaCl. Then we have the DNS, dextrose plus normal saline. So 5% dextrose along with that normal saline. And the third in this category, which is again very, 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 very important, is Darrow's solution. Now when we talk about Darrow's solution, what do you mean by Darrow's solution? Answer is, it's very simple. It is defined as lactated saline. Now what do you mean by lactated saline? Do you know it is a solution which is having the maximum K plus concentration. So maximum K plus concentration is seen in this solution, and therefore, do you know it is having somewhere approximately 34 milliequivalents per liter, and this is too much. Do you know, therefore, this is a solution of choice for hypokalemia. So these things are bit important thing that we need to understand. Now, when we talk about colloids, let us see what is important about colloids. And when we talk about the blood and the blood products, let us discuss about that also. When we are talking about colloids, what is colloid all about? They are nothing but synthetic heavy protein molecules. So synthetic heavy proteins. So they are synthetic heavy proteins, and what is the purpose of these synthetic heavy proteins? The aim is to increase the oncotic pressure. So oncotic pressure, and therefore they induce volume expansion. Now, how they induce volume expansion, for that you need to go to my detailed courses and see. But here I'll just give you a brief idea about the things. So let us talk about the mechanism of working of colloids and let us see them. So let me go down and put a special heading, that is colloids. So when we talk about colloids, since we all know that they are cultured or bioengineered heavy protein molecules, how do we work with them? So suppose you have a patient who is having hypotension. So you have a patient who is having hypotension. Now let us try to understand there are two spaces. One is this intravascular space and one is this extravascular space. So we have intravascular space and we have extravascular space. There are two important things that we need to understand. Now there's a patient who is having hypotension. So now you are planning to give that special molecules. And what are those special molecules? They are colloids. So you plan to give those colloids to them. Now do you know colloids being heavy protein molecule? So they will go inside. They are just like celebrities who will gather the crowd around them. So on addition of colloids, there is increase in oncotic pressure, and there is increase in oncotic pressure. Why? Because they are heavy proteins, and this time it is the increase in intravascular space. So there is increase in the oncotic pressure of intravascular space, and once there is increase in oncotic pressure, what will happen? It will withdraw the water from the surrounding. You know, water will move from the low osmolar state to high, or high osmolar state to low. Answer is from low osmolar state to high, and therefore it will withdraw the water into intravascular space. And this is from where? From the extravascular space, and this is what is very 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 important. When it withdraws the water, therefore it causes what? Volume expansion. And once it causes volume expansion, therefore what will happen, students? There will be correction of hypotension. So correction of hypotension. So these are very 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 simple and important things that we need to understand. However, there is a caution. What is that caution? Try to understand that caution. The caution is they are contraindicated, and this is what is very 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 important. Their colloids are contraindicated in first 12 to 24 hours of any shock. Now, why is this so? So, colloids, they are very important fluids, but they are contraindicated in first 12 to 24 hours of shock. And why is this so? Let us try to understand that. Do you know shock in the early stage or in the early phase? What is the early phase? First 12 to 24 hours. This is associated with endothelial injury, and because of this endothelial injury, there is resultant opening of gap junction. So opening of gap junctions or the leak junctions also. So now try to understand a patient of shock, and just see, this is how the blood vessel is. Yeah, this is how the blood vessel is, and you came around the patient and you gave those magic molecules. So you gave those magic molecules to this patient. Now try to understand by nomenclature. Let me tell you, this is intravascular space, this is extravascular space, and there is no fault of yours. The only thing is that you were not understanding the concept, and these colloids might leak out from this intravascular space into what space, students? Extravascular space. Now, when colloid leaks into the extravascular space, therefore, so now there is leakage due to opening of colloid gap junctions. There is leakage of colloid into extravascular space. Do you know the colloids will do their performance? What is that? Therefore, there is increase in oncotic pressure. But of what space, students? Of extravascular space. And therefore, this is going to cause worsening of shock. Why there is worsening of the shock? Worsening of shock because there will be withdrawal of this fluid from the intravascular space to the extravascular space, and that is why you should be very cautious. Now, do you know this endothelial integrity requires 12 to 24 hours to gain itself back, and therefore once this state of, you can say, 12 to 24 hours is passed off, the colloids are the mainstay of managing any hypotension. So therefore, one very important thing, that endothelium requires 12 to 24 hours for healing, and therefore colloids are preferred after 12 to 24 hours. This is what is very important. Students, last but not least, when we talk about the fluid, the next thing is, and the most important thing is, cannulas. So what is the cannula of choice? What cannula do we use? They are all very important. So when we talk about the cannula, there are 2-3 things that we need to understand. What is the size? What is the color? What is the flow rate? And what is their use? So all these things are very important. So the maximum caliber cannula is what you have as orange. So 14G is orange, and the flow rate is maximum. So it's around 240 ml per minute, may go as high as what? Up to 300. Then we have 16G as gray, and this is 180 ml per minute is the average baseline flow rate. 17G, this is your white, and this is having somewhere around 120 to 150 ml. 18G is what is green, and this is what is having 90 ml per minute. You know, cannulas, they're the favorite questions for majority of the exams. So try to understand this thing, that where are these cannulas used? 14G, 16G, 17G for rapid resuscitation. So for rapid resuscitation, you're going to use these cannulas. When you talk about 18G or green, this is used for all surgeries. But try to understand what to do in case of kids. So for infants or kids, the size is different because the vessel caliber is also different. So for them, we have 20G, which is pink, but not, this is not for the kids basically. This is for all IV infusions. So this is for all IV infusions. So if you want to give any drug, you want to give any, you want to give blood, this is what is preferred. 22G. Now this is from where the pediatric cannula sizes start. So 22G is blue. This is 45 ml per minute is the flow rate. Then we have 24G as yellow. What is the flow rate? 30 ml per minute. And then we have even 26G. This is what is violet. And when we talk about violet, the flow rate is only 15 or 13 to 15 ml. So do you know, this is where you say that it is for pediatric age group. Pediatric age group. So you can understand that 26G probably is used for the newborns. Next is, so we have had a lot of discussion on the fluids, but one very important thing that we all need to understand is the concept of damage control resuscitation, DCR. Now what is this concept of DCR? So we must have heard of DCS, damage control surgery. Now let us discuss something about DCR, damage control resuscitation. What are the important things in damage control resuscitation. Resuscitation. Let us try to understand that. Let us try to see damage control resuscitation. Now, when we are talking about damage control resuscitation, this is not for all the patients. It is for the seriously ill patients in shock who are not responding to the conventional method. So the first rule is limited use of crystalloid. Limited use of crystalloid. Do you know, we all agree that crystalloids are the first line fluid, but you cannot use crystalloid rampantly. Why? Because blood, if you use too much of crystalloid, will be you can say will be diluted, and thus there will be hypo, or you can say dilutional coagulopathy induced. Already there is a patient who has lost a lot of blood. Maybe there is an active coagulation cascade going on which is consuming the coagulation factors, and on that you are diluting the blood. So up to 2 liters, up to 2 liters is what is recommended. Out of this 2 liters, first 500 to 1000 ml, first 500 to 1000 ml can be given as bolus. So you can give this as bolus, and after that you have to do a maintenance. Now you must be saying, sir, the patient is not responding. So use the blood and blood products. So use the blood and the blood products. Now this is what is very important. You can replace the blood by blood, so blood only. Third is, now you must be saying, sir, patient is not maintaining the blood pressure. Don't rush for blood pressure. The higher you aim for the blood pressure, more active is the blood loss. So therefore, one very important thing, take it as a rule of thumb that don't rush for the blood pressure. Keep it as minimum as it can be sustained by the body. So this is known as you are giving the permission to the blood pressure to fall down, and thus this concept is known as permissive hypotension. So what is this concept of permissive hypotension? This is what is very important. Permissive hypotension. What is the concept? This is target map, target mean arterial pressure. What is the target mean arterial pressure that we can keep? 65 to 70 mmHg, and this is what is very important. So target map is somewhere around 65 to 70 mmHg. The fourth in this category, the fourth important thing is try to go for a trial of hypertonic saline. So you can give 100 ml or 200 ml, 3 normal hypertonic saline. This will give you the same effect that a colloid gives you. So trial of hypertonic saline. And then the fifth is use of tranexamic acid. Use of tranexamic acid. Do you know tranexamic acid is actually the clot stabilizer? So tranexamic acid is something which is a gift to the humanity. So there's a trial which is very famous. So tranexamic acid, you can give 1 gram start, and then you can also go for 8 hourly repeat dose. So up to 3 grams of tranexamic acid can be confidently used for the patient, and this is a result of a very famous trial. And what is that trial known as? Crash 2 trial. So crash 2 trial is very important and famous in this category. Along with that, you can also use recombinant factor 7. Now, do you know that factor 7 is the factor which is actually going to ignite or incite the extrinsic coagulation cascade? So recombinant factor 7 is very important. Recombinant factor 7. So tranexamic acid, recombinant factor 7. What else? And along with that, you can use the cryoprecipitates. So plus minus cryoprecipitates. So this is what is damage control resuscitation, and it is very important. Now quickly let us discuss something on the nutrition also. Now when you are talking about the nutrition, what are the important things that we all need to understand? The first concept is what are the types of supplemental nutrition. So when we talk about the types of supplemental nutrition, so I'm going to talk about the supplemental nutrition. There are 2 types of supplemental nutrition. So one is the enteral and one is the parenteral. So one is enteral and another one is parenteral. Now when we talk about enteral versus parenteral, Devraj, hi Devraj. Sir, one question in penetrating chest trauma. Respiratory distress is a hard sign or a soft sign? Always remember, respiratory distress is an indirect result of lot of things. Maybe it could be due to laryngeal edema, maybe it could be due to a direct injury. So this is a confounding thing. When it is in context with neck injury, it is a respiratory distress is a soft sign. Whenever you talk about a chest injury with respiratory distress, it is always a hard sign. Devraj, what is the difference between a hard sign and a soft sign? It is very simple. A hard sign is a sign which is directly indicating, and soft sign is also life endangering, life threatening, but it is indirectly giving you a sense. So, in case of neck injury, respiratory distress is a soft sign. In case of chest trauma, respiratory distress is a hard sign. So, you need to understand the concept. Hard sign is directly indicative, soft sign is indirectly. Like stridor in neck injury. You'll say stridor in neck injury. Yes, when there is laryngeal edema and air is going through that narrow space, there will be cooing sound. So that whistling or cooing sound is stridor. It is indicative of there is a you can say there is a laryngeal edema. So this is what is the concept of hard and soft in this case. So enteral versus parenteral. Now this all depends upon what route. So when you talk about the route, the enteral nutrition is via elementary. नहीं in no, don't get confused. It is crystal clear. It is crystal clear. So and active bleeding, is a hard sign. Pulsatile hematoma is a hard sign. Try to understand both are dangerous. There are a lot of books who are confused whether they say that hard signs are more dangerous, soft signs are less. No, both are equally dangerous. Both are considered as red flag signs. So both fall under red flag condition. Anyways, so enteral nutrition, when we talk about the root is elementary tract. So the root is elementary tract. And when we talk about parenteral nutrition, the root is IV intravenous. Now, when you are talking about which is preferred, the question is which is preferred? Answer is enteral nutrition is preferred to an extent that we write preferred unless contraindicated. So you don't have any choice other than enteral. If enteral is not there, then only you'll go for parenteral. Now students, when we talk about parenteral nutrition and when we talk about the IV routes, what are the popular IV routes? They could be central venous route and they could be peripheral venous route. So try to understand which is preferred, central or peripheral. Whenever you are giving the fluid, it is peripheral. But when you are talking about the nutrition and that too parenteral nutrition, the density, the density, average density is more than 650 milliosmoles. So this is sufficient to damage the intima of the vein and resulting in severe thrombophlebitis. And this is what is very, 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 very important. Very good, Devraj. That is why if you want a short-term IV support, we might go for peripheral. So peripheral, the first drawback of peripheral is short life. Whatever cannula you are using or whosoever is managing the cannula, the life is after 1 week, it will get almost it will get blocked or there will be very severe swelling. So short life, point number 1, and second is severe thrombophlebitis. So because of these things, lot of patients don't agree to go for nutrition after 1 or 2 days. Thus, it is the central venous route which is preferred. And why it is preferred? Because of lot of ease of delivery for a longer time. Now, when you talk about central venous route, again there are two venous route that we have. One is the internal jugular vein and another is infraclavicular subclavian. Now, when you talk about infraclavicular subclavian vein, which is preferred, internal jugular vein is easy to insert. So, if you take that syringe, hyperenized syringe, and you go to this jugular fossa and point towards the contralateral nipple and at 30-degree angle try to prick the needle inside, you'll always hit the jugular and then you can insert it. It is so easy that you can do a single-handed. But the drawback is, suppose if you have a line hanging like this and enteral nutrition, parenteral nutrition is given slowly over a long time. So 15-18 hours, your neck ergonomics has been brutally destroyed, and that is why you feel discomfort. If you go for infraclavicular, so mid-clavicular line, go directly hitting, grazing the lower margin of the clavicle, you will hit against the subclavian vein and then you insert. So if you place a line, that line will be firmly lying over chest. You give it for 18 hours, 24 hours, patient is not having any problem, patient is not complaining of any problem. So try to understand there are two prospects of the central IV routes. So internal jugular vein, this is preferred in case of trauma. So preferred for case of trauma, we go for internal jugular vein. Yeah. And when you talk about subclavian vein, which is the route which is preferred for nutrition, so answer is this. So for nutrition, it is the infraclavicular subclavian vein. Now, we keep on mugging because there are a lot of questions asking what is the route of choice, what is the route of choice in this case, what is the route of choice in this case. Always remember, majority of the cases we go for parenteral until and unless it is contraindicated. So rather than understanding or mugging up what are the indications of enteral versus parenteral, it's better to understand the contraindications to enteral nutrition and contraindications to parenteral nutrition, and they're very, very, very important. So enteral versus parenteral. Let us try to understand these things. So when you talk about enteral versus parenteral, there are a lot of important things. So when you're talking about enteral nutrition, the first thing is severe diarrhea. Remember, diarrhea is not a contraindication. It is severe diarrhea. Then second is severe vomiting. So severe diarrhea, severe vomiting. Then third is severe malabsorption. Severe malabsorption. So remember, this is a trick. Whenever you get a question, they keep on confusing you in diarrhea, vomiting. So you forget the importance of this word severe diarrhea, severe vomiting. Then the fourth is perforation. In case of perforation, how can you give anything via what? Very good, Devraj, very good. Perforation. Then fifth is peritonitis. Peritonitis. Then in case of sepsis, remember, sepsis is a relative contraindication for enteral feeds. And then seventh or the last is obstruction. So these are the classical contraindications for what? Enteral nutrition. When you talk about the contraindication for parenteral, in parenteral you give everything in elemental form, like carbs, lipids and proteins. So when you're giving carbs, you're loading the body with 5 to 10% of dextrose. So that is the case when you have a tendency to shoot the blood sugars. So the first contraindication obviously becomes diabetes mellitus. Now when there is increase in blood sugar, there is flaring of infection. So already if there is pre-existing sepsis, you cannot even dare to give parenteral nutrition because it's just like petrol or the gasoline to fire. So this is what is very important, that it's absolute contraindicated. Why? The only reason is parenteral nutrition shoots up the blood glucose, and hyperglycemia will mask the inflammation and immunity, and therefore the sepsis will turn out to what? Will flare up and will cause maybe multiple organ failures. Third is, you are giving a high viscosity fluid. This fluid will absorb everything and increase the intravascular volume. Thus, if a patient is having congestive heart failure, it will precipitate it or worsen it. So congestive heart failure. You know that carbon dioxide will be released when the CO2, when the carbohydrates will break down. So already if the patient is having COPD, it's a problem. Then fifth is if the patient is having head injury or the patient is in coma. Now this is what is very important. What is the nutrition mode of choice in a comatose patient? Answer is enteral. Why? Because if you talk about parenteral, you are going to give everything in what route? You are going to give everything in the elemental form, and carbohydrates will break down to release CO2. CO2 will cause increase in PaCO2 levels, and this is going to increase the cerebral fluid. That is, it is going to cause vasogenic edema, and something which is causing vasogenic edema will increase the you can say intracerebral pressure, ICP, and the worsening will happen because the cerebral perfusion will go down. The sixth is in case of hypokalemia. So hypokalemia and hypophosphatemia. So hypokalemia and hypophosphatemia, they are important things. And then a state of hyperchloremic acidosis, or hypochloremic hypochloremic alkalosis. So you can say basically acidosis, alkalosis, electrolyte imbalances, they are very important and should be taken care of. Next is, let us not go into the depth of this chapter because this chapter per se is very big. Let us try to understand the basics. So whenever you have a question in your brain, should I start supplemental nutrition for this patient? So it's not like that for every patient admitted in the hospital you start with this elemental form of nutrition, or maybe the parenteral or the enteral. So the next thing that we need to understand, should I start supplemental nutrition? The question number one is, should I start supplemental nutrition? And what should be the answer to this? This is what is very simple. Just give me 1 minute. Sorry. So, okay. So, duration of lack of feed or anticipated lack of feed. What is anticipated lack of feed? Suppose you're planning to go for a Whipples, and post Whipples, you know that patient will not be able to eat properly. That is the place. So, duration of lack of feed or anticipated lack of feed. In this case, if it is more than equal to 7 days, or if it is less than 7 days. If it is less than 7 days, you can easily manage with the fluids, so no need. But if the 7 days have passed, or it is the 7th day, or you are doing a surgery, doing a procedure where after 7 days also you don't anticipate the feed to be started, in that case it becomes very important. So if it is more than 7 days, in that case, yes, start enteral nutrition. Devraj, is sound okay? Is sound okay? Start enteral nutrition. Start nutrition. And what nutrition? Supplemental nutrition. Supplemental nutrition. Now, when you talk about supplemental nutrition, there are two things that we need to understand. What are the two things? The first is parenteral nutrition to be given or is enteral nutrition to be given? You have the answer that unless the enteral is contraindicated, you cannot give parenteral. So the next question is enteral nutrition contraindicated? Is the enteral nutrition contraindicated? The answer is very simple. When you talk about this enteral nutrition is contraindicated, there could be a possibility, yes, it is contraindicated. If it is contraindicated, then you have no option other than to start parenteral nutrition. And if it is no, then start enteral nutrition. Now, if you want to start the parenteral nutrition, what is the next thing? Well, you have to choose IV route. Either it can be peripheral IV route or it can be central IV route. Do you know central IV route has its own risk, complication? You take a proper consent because of its collateral, you can say, damages which can occur in form of cardiac tamponade, pneumothorax, hemothorax, lot of things are there. So when you want to start it, you need to understand if you want to give 1 or 2 sachets or 1 or 2 bags of nutrition, why are you going for central? Then you can go for a peripheral. So there again, you need to answer this question. What is the duration of support required? Duration of support required. So if you require the parenteral nutrition to be given in 1 or 2 sessions only, so if it is less than 1 week, then you can go for what? PPN. What is PPN? That is partial parenteral nutrition. No, peripheral parenteral nutrition. And students, if you require duration for more than 1 week, in that case, you need to go for TPN. What do you mean by TPN, students? Total parenteral nutrition. So total parenteral nutrition, this is what is very, very, very important. So we have PPN, we have TPN. PPN, TPN, they are very important things. Yeah. Why there is, Devraj, why is there so many differences in CT scan protocol, in TBI, in surgery and emergency medicine? बच्चे देखो, try to understand. We believe that in traumatic brain injury there are certain indications that if the GCS is falling below 13, you have to go for. If it is persistent at 13, yes. In case there is any serious comorbidity added to the patient, or the patient is having any neurological deficit or multiple episodes of vomiting, that can be taken as more than one episode now. Or there is a patient who is having some coagulopathy, if the age of the patient is more than 65, there is one very important thing, that in that case, age more than 65, these are elderly people who are prone to develop SDH. So that is again one indication. One more indication is that if a patient is having complaining of amnesia, now amnesia more than 30 minutes is considered significant, and that is one indication. Then if there is a fracture or query fracture, that is one. Apart from that, if the consultant thinks that yes, you want to go for CT scan, you may advise, but this is what is the mandatory protocol set up by the you can say by the neurosurgeons associations of the world, and this is what we follow in ATLS. But there are a lot of things, there are a lot of disparities between medicine and surgery. Try to understand. Head injury, if the patient will come, is always taken to surgery. No physician will take. They will argue. A lot of physicians will argue that this is that, this is that. Try to give one head injury patient to any physician. They will say, "Bhai, surgeon ka case hai, surgeon ko do." So definitely in trauma, surgeons or the orthopedicians, they are the king. So my day, my way, my rules, my attitude. That is what. Next is, let us talk about enteral nutrition. So when we talk about the enteral nutrition, we want to start the enteral nutrition. Again, you need to answer one very important question, that whether you want a long-term support or whether you want a short support. So this is again very significant. So duration of support. Duration of support. Now when you are talking about duration of support, there are three important things. Either it could be for less than 4 weeks or more than 4 weeks. So if it is more than 4 weeks, the concept is different. If it is less than 4 weeks, the concept is different. Now when you are talking about the concept of less than 4 weeks, bache, if that is the scenario, you can insert a Riles tube simply, but the problem is the Riles tube can be inserted, but if the patient is not having a good gastric emptying, that is, stomach has not been able to empty the content, there is an increased risk of aspiration pneumonitis, or the what syndrome? Mendelssohn syndrome. So remember, in that case, if it is less than 4 weeks, then you need to assess the gastric emptying, and we can write this as GE. So gastric emptying or GE. If there is a good GE, good gastric emptying, then what we can do, students, in that case, you can always go for a concept of Riles tube feed, RT feed. If the gastric emptying is poor, then we go for what feed, students? NJ feed. What is NJ feed? Nasojejunal feed. So gastric emptying is very, very, very important. Now, if the support is wanted for a long duration, now this is what is very important. Long duration support. If you put a Riles tube for more than one month, there will be atrophy of the esophageal mucosa. Again, there might be fibrosis and adhesions with the Riles tube also. So if you require the support for a longer time, then you need something permanent. Not permanent, I would say temporarily permanent. So in that case, again, you will ask the concept of gastric emptying. If the gastric emptying is good, then in that case, what to go for? We can go for feeding gastrostomy. If the gastric emptying is poor, then we can go for feeding jejunostomy. Now, do you know what is the big complication associated with feeding jejunostomy, and the same is associated with the NJ feed? When you are giving the carbohydrates directly into the small intestine, do you know there is an increased risk of dumping syndrome? So, what is the most common complication associated with NJ feed? And the same is the complication with feeding jejunostomy. Answer is, this is what is very important, that is dumping syndrome. So dumping syndrome is what is very common and evident. Yeah. Students, let us quickly discuss something about the parenteral nutrition also. Let us try to understand this. Let us discuss something about the parenteral nutrition. So when we talk about parenteral nutrition, there are two, three things that we need to understand. What is that? In parenteral nutrition, we need to understand on the basis of the root, they are divided into TPN versus PPN. What is TPN versus PPN? Answer is, if the root is peripheral venous root, that is PPN. And if it is a central venous root, that is the TPN. Again, one very important thing is the density or the osmolarity You know, something which needs to be given by a peripheral route has to be dilute. So this is low. And when you talk about low, the average density is 650 milliosmoles, 650 milliosmoles per liter. Still, it is twice the osmolarity of the blood. You can understand the problems. And here it is high. So when you're talking about TPN, it is more than 950 milliosmoles per liter. So these are some important things that you need to understand. Again, when we talk about parenteral nutrition, it is of two types. It is either 2 in 1 or it is 3 in 1. So 2 in 1 versus 3 in 1, both TPN and PPN occur in form of 2 in 1. You know, this is the joke of the millennium or joke of the era, that 2 in 1 is PPN, 3 in 1 is TPN, or vice versa. But say, laugh aloud on this joke if you hear someone talking like this. Both 2 in 1 and PPN, 2 in 1 and 3 in 1 are available in TPN PPN formulation. It is only the country standards. Like in developed countries, it is 3 in 1. The same company like Prasines Kabi, Baxter, they're manufacturing 2 in 1 for US, and for India, they're manufacturing 3 in 1. So this is what is the difference, developed versus developing country. In my routine classes, I have already discussed this thing in detail and depth. So what are the basic elements? Carbs, lipids, and the proteins. So what is the basic ratio of distribution by percentage volume? 70%, 20%, and 10%. And when you talk about 2 in 1, it is 70 to 80% is what is carb. Try to understand nothing known as lipids. Proteins, if you talk about, it is 10 to 20% is protein. And along with that, there are something which are known as others. Now, when you talk about others, what are the things that we have in this others category? You can have the sterile water for dilution. So sterile water for dilution, you know, you are adding 70 to 80% of the carb. The patient will have a very severe spike of what? Blood sugars. So insulin. Then to prevent stress-induced gastritis and bleeding, PPIs. Along with that, important minerals, vitamins, and trace elements. So these are some important things that you need to understand, and these are very important things. So this is about the parenteral nutrition. The next thing that we need to understand are the complications of parenteral nutrition. I'm just cutting short this chapter because otherwise I usually take 2-3 hours to complete this. Yeah. So when you talk about this concept of complications of parenteral nutrition, so when you talk about complications, I'll not discuss all of them. The most common complication, answer is hyperglycemia. So it is hyperglycemia which is the most common complication. The second most common is the fluid overload. So we have fluid overload. The third is the electrolyte imbalance. So when we talk about electrolyte imbalance, what is so important? Do you know electrolyte imbalance is the most common cause of mortality in the long-term TPN therapy? So in long term therapy, this is what is very 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 important. Apart from this, you have acidosis, you have uremia, you have hepatitis, or hepatitis, I'm saying hepatic failure. This phenomena is known as parental nutrition induced liver failure, PNILF. So this is very 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 important. Hello Shrey, how are you, how are you? And these are the important complications that we have. One very important complication from examinations perspective is refeeding syndrome. So when we talk about refeeding syndrome, it's not a very common complication, but yes, what is refeeding syndrome? Refeeding, as the name is, when you start the feeding again. So if there's a patient who has been on long-term starvation and you start with the IV parental nutrition, there is a sudden efflux, or you can say sudden mismanagement of electrolyte, and this results in hypokalemia, hyponatremia, hypocalcemia, hypomagnesemia, out of which hypophosphatemia is very important, very 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 important. So electrolyte correction and slow titration of fluid is very very important in this case. Shreya, I'm fine. I hope you people are doing fine, preparing for the exams and trying to catch up with you every day now on this small revision session based program on YouTube. So I'll be running this on my channel also very soon. We'll be getting you a lot more interesting topics, and this marathon will continue. I would keep on adding the topics in this series. So I hope you enjoyed today. Till then, bye bye, bye bye, bye bye. So stay healthy, stay safe, enjoy, eat well, sleep well, drink well. Till then, bye bye.